A term 1-month-old infant is brought in unconscious following a cardiorespiratory arrest. I am showing you an axial brain CT scan. Describe the findings.
Um, let's see. Yes. The axial contrast-enhanced brain CT scan demonstrates bilateral, symmetrical, low-density or hypoattenuation within the basal ganglia, specifically involving the putamina, caudate heads, and thalami. There is mild diffuse effacement of the surrounding cerebral sulci. No intracranial hemorrhage or extra-axial collections are seen. These findings of symmetric deep gray matter hypoattenuation in a term infant are typical of severe acute hypoxic-ischemic encephalopathy.
Explain how the pattern of hypoxic ischemic brain injury differs based on gestational age and the severity of the insult.
In premature infants under 34 weeks of gestation, the deep white matter is most vulnerable, leading to periventricular leukomalacia, which spares the cortex and deep gray matter. In term infants, the pattern depends on severity. A mild to moderate insult causes ischemia in the cerebral watershed border zones between major arterial territories, sparing the deep gray matter. However, a severe, acute insult in a term infant affects the most metabolically active structures at this age, which are the deep gray matter nuclei, specifically the thalami, putamina, and brainstem nuclei, as well as the perirolandic motor gyri, which is the pattern seen here.
What is the differential diagnosis for low-density basal ganglia on CT, and how can we differentiate between them?
The differential diagnosis for bilateral symmetric basal ganglia hypoattenuation includes severe hypoxia-ischemia, profound systemic hypotension, acute hypoglycemia, carbon monoxide poisoning, and metabolic disorders like Wilson's disease. Clinical correlation is essential. Hypoxia, ischemia, and hypotension typically have a history of arrest or birth asphyxia. Carbon monoxide poisoning classically shows severe globus pallidus necrosis and is linked to environmental exposure. Hypoglycemia presents with seizures and low blood sugar levels, while Wilson's disease is seen in older children or young adults and presents with liver dysfunction and neuropsychiatric signs.
Describe the differential diagnosis for high-density or calcified basal ganglia and provide a helpful memory aid.
High-density or calcified basal ganglia can be recalled using the mnemonic PI maps. P stands for physiological calcification, while I represents congenital infections like cytomegalovirus, toxoplasmosis, and rubella. E represents endocrine causes, including hypoparathyroidism, and M stands for metabolic disorders like FAR disease, Lee disease, and Wilson's. Finally, A stands for perinatal anoxia. P represents poisoning from carbon monoxide or lead, and S stands for syndromes like Downs and Cockayne's.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these CT findings with any prior cranial ultrasounds or MRI scans. I would suggest urgent clinical correlation with serum glucose, blood gases, and toxicology screens. I would recommend a brain MRI with diffusion-weighted imaging, DWI, and magnetic resonance spectroscopy once the patient is hemodynamically stable, which is the most sensitive method to evaluate the extent of tissue injury and prognostic recovery. Finally, I would document the findings, check for signs of cerebral edema, and communicate the findings directly to the pediatric intensive care team.